pyramid. Okay, let's go through them. I think this is a bit harsh for the simple reason, steppies, for the simple reason that I can understand you don't, it is not projecting very well for you, steppies, and the arrow is slightly off. So it's a bit harsh. So I think I'll disregard that. The point was that the steppies is visible here. And this flower, of course, is cochlea. This thing is the vestibule. Now, this answer, I think there is a typo here. This mastoid air cell should not be here. This is facial nerve. Mastoid, it is the descending. And if somebody has said that there is a pyramid here, so that is fine. But my main point was this black dot, which is the descending. So this is a typo. So disregard that. Apologies for that. Now, last, number 1. Number 2. Number 3. Number 4. Number 5. So number 5 is regarding this bone here. And number 6 is this black space, the ear. The space between this incus and the bone. And number 7 is this this structure. This, which is projecting here. Yeah, this is a bit harsh because there is a bit of partial voluming. So this is, this is the tympanic portion and there is a partial voluming. This is the lateral semicircular canal. But I do accept that this is a bit harsh. Prozac space out of the malleus and part of the cochlea. If you have mentioned the turn, it is fine. This is the internal ear. This is the vestibule. Right. So on a coronal, this one. What is number 1? And number 2? Labyrinthine facial nerve. And number 3? Tympanic facial nerve. And this one is the bone, and this is that space, this black space. Excellent. So these are the answers. All of you got it right. So, sorry, I think I've already shown you the answers. Let's do it in any case. So number 1. Number 2. Three, 4, 5. So this is the vestibule, the superior semicircular canal, the lateral semicircular canal, the tympanic portion of the facial nerve. A bit of repetition here. So I think this is easy, where we have got the vestibule, the superior semicircular canal, the lateral semicircular canal, and the tympanic portion of the facial nerve. Okay. Last section, coronal. Number 1, number 2. These are harsh because you just see them partially, but you can imagine something going superiorly, you can imagine something going laterally. And then you can see that something is going inferiorly. And then this thing here, number 4. Yeah, very good. So these are excellent. A sagittal sequence. So what is number 1? Good. And what is number 4? Number 4, please. Excellent. So that is the stylomastoid foramen and facial nerve. Okay, so this was the case when we started. So this is the scutum which is eroded. There is soft tissue opacification which is involving the epitympanum as well as the mesotympanum. This is the tympanic portion of the facial nerve. This is the labyrinthine. Nothing is happening there. On this slice, we don't see the lateral semicircular canal, but we can commit that the tegment tympani is not eroded. So this ossicle maybe looks slightly attenuated, maybe slightly attenuated. So this was just to develop anatomy. Now we will take 5-minute break, and then we will see few in the last hour. We are going to see viva cases of the temporal bone. Candidate 2, you are with us?
Yes.
Okay. So now we are going to see a few viva cases in the last 1 hour. First thing is cholesteatoma. Now, let me tell you a few theoretical points about cholesteatoma before we see the cases. Uh, Basically, what is happening in a cholesteatoma that so this is from Chapman. Uh, Cholesteatomas, of course, can be congenital and they can be acquired. We are talking about acquired cholesteatoma here. And the classical location includes pars flaccida, which is 80%, pars cancer is 20%. Candidate 2, you can see my slide, Chapman slide.
Yes.
Okay. Now, you have to remember the pathology, what is happening. Basically, in cholesteatoma, you see here that because of otitis media, there is retraction membrane and the skin cells, they go into the medullary cavity. And you remember that one of the properties of the skin cells is exfoliation. So they keep growing and they have got keratin inside. That becomes a ball and that ball keeps growing. And this keratin has got some properties of absorbing the bone. It takes years and years to develop, but gradually it will destroy the structures. Key finding on a CT scan are two. One is that non-dependent opacity with bony destruction. Where and how the bony destruction will be, we will see. But how good are we on a CT scan to diagnose cholesteatoma? Our sensitivity and specificity is not very good, which is obvious. But these are the two key points which we remember. And you see, this is the concept, focal accumulation of exfoliated keratin within stratified squamous epithelium. CT scan, this will not enhance either on CT scan or on MR. Surrounding granulation tissue can enhance. Key point to remember is that cholesteatoma can cause on MR, it will show restricted diffusion. This is key point to remember. Actually, you remember in CNS, we have done epidermoids. Now, histologically speaking, epidermoid is the same thing as cholesteatoma. The only thing is that when it is within the intracranial cavity, we call it an epidermoid, which is when it is in the scalarium, we call it an epidermoid. But in the temporal bone, we call it a cholesteatoma. We have made life, uneasy for ourselves, difficult for ourselves. But remember that it will show restricted diffusion. So with that background, if you see this picture here, what is happening? This is a classical cholesteatoma, which is at the Prozac space. This is partial cholesteatoma. So if you are an ENT specialist and you are doing horoscopy here, you will actually see it, an early white type of appearance. And many a times the clinicians, they tell us that I can see a cholesteatoma. Please see what is happening inside. Tell me the roadmap, what to do when I'm going in, what to expect. So this is a classical pars flaccida cholesteatoma. And gradually it will erode this scutum. This is in the Prozac space, and it will erode this ossicle. But then there can be pars tensa cholesteatomas also. It can be in other parts of the medullary cavity. They can be very large. Look at this example where it has eaten up everything. And look at this tegment tympani, which is eroded. Lateral semicircular canal is eroded. It can erode the facial nerve canal. ossicles are eaten up. So all of these things can happen. So if you see here, pars flaccida, pars tensa cholesteatoma. The main thing to remember is non-opacity with non-dependent opacity with bony destruction. Now look here, candidate one. If I tell you that this is a cholesteatoma, can you prove me right? Sorry, candidate two. Can you describe it? What's happening?
There is a soft tissue attenuating lesion in the middle ear cavity abutting the malleus and incus. There is no erosion of the adjacent bone. This is in the dependent portion, so and there's no erosion, so it's unlikely to be a cholesteatoma.
If you see here, it's vice versa actually. The dependent portion is this one, right? This is non-dependent, and this is classical. This is the Prozac space. We are at the level of the epitympanum. This is the head of the malleus, and this is the incus. And this thing is eroding it. This is a classical pars flaccida cholesteatoma, exam cholesteatoma on an axial slice. On the other hand, this is a non-dependent opacity. If you can see, because automastoiditis, acute over chronic mastoiditis can also cause bony destruction. But if you see, there is a fluid level here, and this is a non-dependent cholesteatoma. Non-dependent opacity. Now, so our specificity to say that this is a cholesteatoma is not very good on a CT scan, but here we can be less confident. Here we are more confident. Now look at this case where there is opacity here and there is a bit of erosion of this structure. What is this structure? Candidate 2?
That's the scutum.
You see, we are at the level of lateral semicircular canal. This is the lateral semicircular canal, just like this. And on an axial slice, there is a bit of, erosion. So, so the point is that there can be erosion here. Here in this case, what is happening that there is opacity. Of course, these are harsh cases because I'm just showing you a single slice. Here, there is a complete erosion, just like this case, just like this case. I'm just showing you a particular level, should I say. Now, candidate 3, are you with us?
Yes, I am.
Okay. So, candidate 2, thank you very much.
Thank you, sir.
Okay. Now, these are the features of cholesteatoma which you have to remember. So, which kind of, one is middle ear specification, then erosions. So what to look for? There can be scutum erosion, as I've told you, ossicular erosion, ossicular displacement can be there. Sometimes there can be expansion of adductus ad antrum, but a favorite of the examiner will be lateral semicircular canal fistula. And you have to really develop your eyes on this. This is an exam scenario because these patients will then present with a lot of balance abnormalities. Please remember that cochlea is involved with, sound as in deafness, etc. And the vestibule and the semicircular canals are involved with balance. So if there is fistulization, the patient will become very symptomatic. And then you have to see, so these should be your pertinent negatives or positives in your, when you are describing it. Segment tympani, is it eroded? Facial nerve canal, is it dehiscent, etc. So these should be your pertinent negatives. Just describe it for me. This is a case of cholesteatoma, but can you just describe it? Candidate 3.
So thank you. So this is a cone down CT image of the
Your volume is very low.
very low.
Say again.
I said this is a coned
Yeah, yeah.
down.
Now I can hear you loud and clear. Please continue.
Yeah. This is a coned down CT image of the inner ear. In the axial slice, there is a soft tissue density within the inner ear. However, there is no bony erosion of the lateral semicircular canal. It appears intact, no dehiscence in there. And then I'm just looking at the coronal image. The scutum appears to be eroded. Then the tegment tympani appears to be intact. Can't visualize the ossicular chain here.
Okay, very good. Well done. So basically, the exercise is that.
In summary,
Excuse me, because of time factor, we'll stop. We'll continue. Let me take over. So well done. So there is a complete opacification of the middle ear cavity. The ossicles are completely destroyed. This scutum erosion is, not very emphatic, but maybe we use a word blunting of scutum. You can use that. And you did well where you ruled out segment tympani. Yeah, that's fine. Good, well done. Now here, this is a known case of cholesteatoma on this side. What is your finding here? What's happening?
I can see that the lateral wall of the lateral semicircular canal has been eroded. So I'd call this lateral semicircular canal dehiscence.
Excellent. Well done. So this is a favorite, and you have to develop your eyes. This is what I call the Clint Eastwood sign. This is the old movie 1966, Good, Bad, and Ugly. This is his revolver .357 Magnum, and this is the barrel. This barrel should touch bone. This is the hammer. This is the superior semicircular canal. So this is and this is the vestibule. So this is the vestibule, the superior semicircular canal, and the barrel. This barrel should touch the bone. If it does not touch the bone, as in your case, this is means dehiscence. And you have to develop your eyes to pick it up on an axial also. So on an axial, for example, if you see here, this is dehiscence on a coronal. But on an axial also, you can see it. This is the tympanic portion, and this one here is the lateral semi, which is eroded. Okay, a very big cholesteatoma. What is it doing?
So these are cone down CT images of the inner ear. I think there is an increased density of the bone, sclerosis of the middle ear bone, and the ossicular chain appears to have been disrupted.
This part of anatomy, where are we? Landmark is this. Landmark is this.
So we're in the inner ear.
Yeah. Is the inner ear normal?
No, it's not.
Okay. So the point I wanted you to just see here is that cholesteatomas at times can be so large and so long-standing that you will see cases in which they will destroy even the inner ear. So just wanted to show you an example. This one, I think you have already done. Okay. Now, this is a new world. What is happening here is patient has got right-sided mastoidectomy. And Is there a recurrent cholesteatoma? That is the question. And we have done various sequences. I will tell you why they were done. This is a T2 weighted sequence. This is a T1 post contrast, which has been delayed post contrast, is 45-minute delay. And this is a DWI. So candidate 3, what is your conclusion?
So my conclusion is that there is a soft tissue mass, it is bright on T2 and doesn't show significant enhancement on post-contrast, but is showing some restrictions. So with the conclusion, it's going to be a cholesteatoma because it restricts.
Yeah, so let me now tell you something basic about the role of MR in cholesteatoma. So initially, people used to just do CT scans for cholesteatoma. Then people realized that there is a role of MR. And the initial role in which they started was in recurrent cholesteatoma. So recurrent cholesteatoma is a nightmare on CT. Why? Because recurrent means that it has been already operated. They will do a partial, mastectomy or a, even more extensive type of mastectomies. So there will be just soft tissue visible on CT scan. Is there a recurrent cholesteatoma? And it was a nightmare. So people developed this protocol. In a post-op temporal bone, you can see three types of things can be visible. One is granulation tissue. Second thing is fluid. And the third thing is recurrent cholesteatoma. Now, cholesteatoma will be high signal on T2 weighted sequence, and it will show restricted diffusion. So you did very well where you picked it up. If it was only fluid, it will be high signal on T2, and it will not show restricted diffusion. So granulation tissue can be high signal on T2, but it can show delayed enhancement. Now, because it is sort of granulation means fibrosis. So the protocol was that you give contrast, and because there is not enough vascularity there, you do a delayed post-contrast 45-minute. In conclusion, an MR with this protocol can differentiate between fluid versus recurrent cholesteatoma versus granulation tissue. So there was a time when people used to do this. We have also done in our department. Then we realized that what is the clinical difference of diagnosing a granulation tissue versus fluid, and there is nothing. So people have deleted this sequence, this delayed, and it used to create a lot of administrative issues. 45-minute means you have to, should the patient be on the table, or can somebody else can be scanned and then the patient comes back. So now we are using just DWI, T2s and DWI to diagnose cholesteatoma even in regular cases. So the use of MR has become more prevalent. Initially, it was just in post-surgical cases. Now people are using it. We have also used many a times just to diagnose. So this was one case. Another case, candidate 3 for you. This is post-surgical cholesteatoma, any recurrence. So you can see this T2. This is delayed post-contrast, and this is DWI. Over to you.
So these are coronal images of the brain. Then on the T2 image, it's high signal. Post-contrast, can't appreciate much enhancement. Then on the DWI, I can't see any high signal there. So impression here is that this is not a recurrence. It's likely going to be a granulation tissue.
Okay, if you say that there is a subtle enhancement, then your diagnosis will be that this is granulation tissue. On the other hand, if you say that there is no enhancement, then this will be just fluid, not. But the main clinically important finding you have picked up very well Clinically important finding was that is there a cholesteatoma or not. Please remember, if there is a cholesteatoma, they will go in and they will remove it because it will cause more and more destruction. This is an interesting one. Sorry. Okay. So uh, if you see here, this one did not enhance. This one is showing slight peripheral enhancement. This is so at times this can happen. The surrounding granulation tissue can enhance, but it is showing restricted diffusion. So this is what candidate three.
Cholesteatoma.
Yeah. Now this is bilateral. So I want you to tackle right and left. Let me describe. This is 16-year-old previous bilateral surgeries, any cholesteatoma. First of all, tell us what is happening on the right. Just concentrate on the right, and then I will ask you the left. Over to you.
All right. So the right is high T2 signal, shows some enhancements, but no restriction. So
Conclusion.
this it's granulation tissue on the right.
Excellent. And on the left?
Then on the left, it's high T2 signal and shows no enhancements, but there is diffusion restriction. So that is recurrence of cholesteatoma.
Excellent. Okay. In trauma world, uh, always beware of temporal bone, fractures as well as ossicular dislocations whenever you are reporting a CT scan, particularly in the exam. Please remember, at the level of epitympanum, the head of the malleus sits here with the body. We call it the ice cream cone type of. So it should be sitting here. It is dislocated here. And of course, there is a longitudinal fracture here. I'm not going into details of longitudinal and transverse fractures of the temporal bone and what it can do. But main thing I want to highlight is that always look here to rule out an incudomalleolar dislocation. And if you're doing a Viva case and the examiner might give you half a mark or 1 mark more, look at this example where what is your finding here, candidate three? Ossicles wise?
Yeah, I think there's also called the malleus and the incus are dissociated. Yes.
Yeah. So incudomalleolar dislocation.
Dislocation.
Yeah. Okay. This case, I have not given you a bone window, so let me talk through it with you. If you see it, and then I'll ask you leading question. So if you see here, this patient had previous history of mastoid surgeries and chronic osteomastoiditis. So you can see a bit of bony defect here. But with contrast, if you can concentrate here, if you can concentrate here, concentrate here, and concentrate here, and let us know what is your conclusion.
So these are still images of the Excel contrast enhanced CT images of the base of the skull and lower parts of the brain. So there is a low density filling defect seen within the sigmoid sinus, and there appears to be bony irregularity and disruption at that area. So I'm just suspicious of a thrombus, but looking externally as well, there appears to be some soft tissue, enhancing soft tissue, external to the region, seen at the upper right image. To me, looks like there's some.
Yeah, this one here.
Yes, some external soft tissue enhancement. I'm not sure what that could be, but the filling defect could represent thrombus. Then looking externally, that one could be due to an infection.
Thrombus where?
Within the sigmoid sinus, there's a low No
Okay,
density.
that's fine. That's
And
fine. Okay, I'll take over. Now, please remember that complications of various kinds of infection is most important case for your exam. And if it is paranasal sinuses, if it is orbit, if it is temporal bone, so because as a general radiologist, you should know that. Now, in this example, what is happening? That there is lot of, so of course, the windowing is poor, so that is why. But having said that, you can see that there is a soft tissue abscess here. You can see this filling defect here. So there is transverse sinus thrombosis. This is jugular vein, and this is, if you see, this is jugular vein, and this is jugular vein, and this is extension of the same thrombus, which is extending into the jugular vein, which in the carotid sheath. So this is just an example of complication. Now, this, on the other hand, is a classical exam case. Now, because of time factor, I'm going to talk through a few findings, and then I will ask you, candidate 3. Now, if you see here, this was clinically extremely, the patient had a lot of ear pain, fever, and headache. Now, this is what is happening. We can see opacification of the mastoid cells. We can see the opacification of the middle ear. And if just concentrate on this one and concentrate on this one, and what is the main finding? Over to you, and what is your conclusion?
so axial CT images in bone window and cone down images of the ear, bone window in coronal sections. So there's increased sclerosis of the bone of the
Don't worry about sclerosis. That is just because of the windowing. Don't worry about it.
right. So there appears to be a locule of gas within the temporal um, within the temporal
Within the middle ear
bone.
cavity, right?
Uh, yes. Apart
Is it
from the
middle ear? I'm using the wrong word. Middle cranial fossa, right? Okay.
yes,
Now,
maybe.
so have you
So that
seen any bony abnormality? What is your conclusion? What has happened, and what will you do next?
I believe there is a bony erosion of the ossicular chain because I can't see the ossicles now. I would like to take this further by having an MR done.
MR done.
Yes.
So now the key point here is, and it is a classical exam case. You picked up the locule of gas very well. This clinical is very revealing, but the key finding is that there is something acute inflammation happening, and even here there appears to be bony erosion. And this is coronal, so this is tegmen tympani. This is what we call tegmen mastoideum, which is superior to the level of the mastoid. There is a dehiscence here. This means there is acute bony destruction. Now, this type of things can happen because of acute otomastoiditis. So, and please remember bony destruction. Once there is bony destruction, you see cortical and trabecular erosion. The complication includes subperiosteal epidural brain abscess, venous sinus thrombosis. You did well when you asked for an MR, and here you are. So, what is happening on this MR? If you can concentrate here, concentrate here, concentrate here, this is that gas locule. How will you tackle it? What will you say? Over to you.
So looking at the MR images, especially the post-contrast, T1 post-contrast image, there is enhancement of the, I believe, the meninges around the um, left temporal lobe, and there appears to be filling defect on the MRA images, filling defects of the transverse sinus. So these findings are suggestive of venous sinus thrombosis. I'm just trying to see if there's any collection of abscess collection anywhere within the brain parenchyma. I can't see. Then just looking at the neck. So
That's fine. So you did well, and you were trying to pick up an abscess, which was fine. Good, well done. There is no abscess. Let me tell you the points here. Now, when there is extension of inflammation or infection, what can happen? First of all, look for dural enhancement. When there is dural enhancement, you know that the infection has gone into the dura, and then, subsequently it will go more, into the parenchyma. There is a term which we use, cerebritis, which is a non-specific term. If you see here, there is edema here, but high signal. But as you were trying to pick up, there is no abscess formation. So this, once you see this, you just call it, cerebritis. And you can see the main finding is that there is dural enhancement. There is some high signal, but there is no abscess formation. The gas locule is there. The gas locule has got a bit of, again, dural, meningeal enhancement is there. And then there is sinus thrombosis. This is another classical case which can come in the exam. Now, this case, I am going to go through it myself, and I might ask you some leading question. This is just to give you the concepts of perineural spread of tumor. I believe perineural spread of tumor it's a difficult one, but particularly in regard to foramen ovale, you must know it for your exam. Having said that, this is a very good example. This patient came to our hospital since 2 years was coming with facial nerve paralysis on the left side. And the imaging which was done was CT temporal bone, many a times MR was done by the neurologist. But the key point which everybody forgot, that adequate imaging was not done. Parotid, because parotid lesions can also cause facial nerve paralysis. Now, in this case, what happened was that there was, in the deep lobe of the parotid, there was a tumor. This tumor was adenoid cystic carcinoma. Now, if you look carefully, although this is not classical temporal bone imaging, it is a brain type of protocol. Having said that, you can pick up the findings. So first of all, there is a lesion here, and there is some enhancement. Now, if you look into the middle cranial fossa, the IAM, you can see, cochlea sitting here, you can see this enhancement. So the 7th nerve, 8th nerve, they are enhancing. If you look very carefully where I am pointing out, this is the descending facial nerve, and it is causing enhancement. If you see here, this is the Meckel's cave on right side, this is the Meckel's cave on left side, and there is a bit of enhancement. So this is, something else is happening. If you look carefully, because classically for head and neck, you should have a fat saturated sequence. It is not fat saturated, but what is happening that there is perineural spread into the foramen ovale, which is going here, but not going more proximally. So what has happened is that if you see this picture, it tells you everything. When there is a tumor in the parotid gland, there can be perineural spread through the facial nerve, and it can go up and go into the IAM, just like our case. Similarly, in masticator space tumors, it can go up like this into the foramen ovale. So in our case, what has happened is that, please remember that anatomy-wise, there are some connections to the lingual nerve between the seventh and the fifth nerve. So part of the tumor has gone into the fifth nerve, and from there, perineural spread into the Meckel's cave is visible. This is the coronal of our patient, coronal T2 weighted. And you can see this enhancement, and you can see how it is going into the foramen ovale. This appearance you must remember, and this is an exam scenario. Other tumors can also be asked like this. So this was perineural spread. This is perineural tumor spread around the seventh nerve. Okay, this is your last case, and then we'll go to candidate 4. Now, candidate 3, if you see here, let me talk you through this case. We have got bone windows. We have got some specification here into the middle ear cavity. We can see a bit of, around the jugular foramen. Compare this jugular foramen with this jugular foramen, and there is some soft tissue which is going into the middle ear. When we gave contrast, though the windowing is not very good, but having said that, this is the appearance on contrast, and this is the appearance on contrast. Please describe the lesion and give me your diagnosis. Over to you.
Okay, there are multiple still images of the base of the skull. In coronal axial, there is bony erosion of the jugular foramen, and there is a enhancing soft tissue mass seen within it. So with regards to this location and the irregularity seen here, my first differential will be glomus jugulare tumor.
So what is the glomus jugulare?
It's a type of paraganglioma, quite similar to glomus tympanicum or pheochromocytoma or.
So everything is correct, whatever you are
this
telling
particular
me.
location.
Yeah, but I am not satisfied with the location. So everything, whatever you told me, is absolutely correct. But you use the word glomus jugulare. This, what part of anatomy is this?
Oh, sorry, tympanicum.
Okay, tympanicum. But
yes,
you are right that it is also involving the jugular foramen. Indirectly, we are just debating the word here to use. It is from the jugular foramen, it is going into the middle ear cavity. So this type of jugular, glomus tumor is known as glomus jugulotympanicum. Are you with me?
yes.
Okay, so good. Let me tell you the concept. Now, glomus tumor is a very, very important case in the exam. Now, please remember the location changes the name of the tumor. So you are absolutely right that just like I was giving you the example of cholesteatoma versus epidermoid, that when it is in intracranial cavity or the calvarium, we call it epidermoid, and in the temporal bone, we call it cholesteatoma. Similarly, in head and neck, we call it a glomus tumor, and in adrenal, we call it a pheochromocytoma. Histologically speaking, it's similar. Now, anatomy or the location changes. What is the concept? This is glomus tumor are chemoreceptor cells along the carotid sheath. So please remember they are in the carotid space. Now the location can be in head and neck, there can be 4 different locations. When it is at the bifurcation of the common carotid artery into internal and external carotid artery, we call it a carotid body tumor. When it is at the jugular foramen, We call it a glomus jugulare. When it is in between the bifurcation and the jugular foramen, we call it glomus vagale. So please remember, because in the carotid space, vagus nerve is also there. When it is just in the tympanic cavity, as in the middle ear cavity, we call it glomus tympanicum. But when there is a large tumor which goes from the jugular foramen and penetrates and goes into, because this is just superior to that, you remember the anatomy, we will call it glomus jugulotympanicum. So this is a glomus tympanicum, this is jugulotympanicum, and this is only tympanicum. These are very vascular tumors. So they will enhance like anything. And another thing is they will cause permeative bony destruction. So classical scenario is that on a CT scan, this is another differential diagnosis, jugular foramen lesion, glomus jugulare, and it is middle ear cavity, and this one is again glomus jugulare. So the key point to remember is 2 points. On a CT scan, look for permeative bony destruction. So look carefully on this case. This is another example. Look at the margin of this lesion and look at the surrounding bone. And this is a classical example of permeative bony destruction. Permeative bony destruction. When you give contrast, it enhances like anything. This permeative bony destruction on a CT scan makes it, because of permeative bony destruction, you can sort of discriminate it with a schwannoma, because there can be schwannomas of the 9/10 of 11 nerve passing through the jugular foramen, and they can also enhance, but they will cause expansion of the bone. They will not cause permeative bony destruction. On a CT scan, that is the key to differentiate it with a schwannoma. On an MR, there is another sign, and we call it salt and pepper sign. Usually, it is seen in a glomus tumor, which is more than 2 centimeter in size. Basic concept is that glomus tumor is extremely vascular. So on a non-enhanced T1 weighted sequence, please remember, non-enhanced T1 weighted sequence, you can see a salt and pepper sign. What is salt and pepper sign? You might see some micro hemorrhages, which are high signal on T1, and you can see filling defects because these are very vascular arteries which have got high flow or vessel, should I say, which have got high velocity flow, which appear as low signal. Salt and pepper sign on an MR, on a non-enhanced T1. Same thing you can see in carotid sheath, as I have told you. And on a CT scan, you can see this bony destruction. Okay, thank you, candidate 3. Is candidate 4 with us?
Hi.
Yeah. Okay. So this one is a mass in the same location. This is an MR scan. This is fat saturated T1 weighted sequence. You can see something here, something here, something here, something here. Can you describe it? What is your differential?
So we've got axial sequences through the lower part of the cranium. And so T1 post-contrast, post-SCAD images, selected sequences. And I can see that within the left posterior fossa, there is an enhancing lesion. And I'm just going to interrogate the other images. So it seems to be in continuation with where you would find the IJV. So I think it's where the vessel would exit the foramen. So I think the left IJV is occupying the left jugular foramen.
Excellent. We are in the same differential diagnosis. So this is a tumor which is sitting in the jugular foramen. What is going to be your differential for this?
So a neural tissue lesion such as a schwannoma or a paraganglioma, but I don't see that salt and pepper classic flow void appearances to it. So I would probably say, because it's expansile and not destructive or osteolytic, I would say schwannoma would be my top differential.
Okay, excellent. Please remember, I've not given you all sequences, but you have tackled it very well, and it was a schwannoma. The key thing is, look at this picture, and you will remember it. Jugular foramen schwannoma. Just like a schwannoma anywhere, it will cause expansion of the bone. It will not cause permeative destruction. So remodeling of bone. Remember that in ribs and spine, etc., you will see the remodeling because of schwannoma. And this is an example from StatDX. Look at this, how it has caused expansion. On the other hand, you remember this picture of permeative bony destruction. So this is how you differentiate between the two. And these are the top two differential or jugular foramen maps. There is I will show you this kind of meningiomas in subsequent sessions, but just to let you know, sometimes what happens is that meningiomas, they penetrate the bone, and it can cause hyperostosis. And when that will happen, it will cause sclerosis of the bone. So in the differential diagnosis in your book, you see here, skull-based lesion, not specific to jugular. For example, meningioma is there. So just to make a point that this is an example from StatDX. You can see this dural enhancement with this expansion here. And these kinds of cases will cause a lot of sclerosis. Classically, the examiners will show you a plain film where there will be sclerosis. And then, when you take it to cross-sectional imaging, it will be a meningioma. Take-home point is that there are types of meningiomas which penetrate into the bone, and then they can cause hyperostosis. And I'll show you these cases subsequently. But it can happen in the jugular foramen also. Okay, this is a tongue. The clinical presentation is abnormal tongue. Over to you, candidate 4.
So we've got selected sequences, T1 stare and T1 post-contrast sequences through the floor of the mouth. And we can see that there's area of increased signal intensity within the left side of the tongue muscles, and on stare imaging it demonstrates high signal intensity, and on the post-contrast study there's no particular enhancement that I can appreciate, though it does look symmetrical, and given that it's high T1 signal on that side of the tongue, it makes me concerned that there is a hypoglossal nerve lesion on the affected side, which would give you muscle atrophy of the tongue and denervation.
Excellent, well done. So, the bar in FRCR exam is going up and up. And I remember maybe about 10, 12 years ago, somebody who was my student, he got this kind of a case in the exam. So this is a case of tongue atrophy. And there is a concept of what we call denervation. So what will start is, I'll talk you through the case once I give you a bit of theory behind it. What happens is that the 12th nerve, it supplies the intrinsic muscle as well as the extrinsic muscle of the tongue. Now, if a patient presents to you with atrophy of the tongue, the first thing is that you will tell the examiner that I want to scan the whole neck till the base of the skull. Anatomy, remember the anatomy that hypoglossal canal is sitting next to the carotid space. So there might be a lesion at the base of the skull, and which can cause motor denervation. And in this particular case, there was again a glomus jugulare, which was causing it. Because the hypoglossal, as soon as the 12th nerve comes out of the hypoglossal canal, it is in the carotid space. So, of course, this was an infiltrative lesion which has caused its denervation. Now, this is the concept. So, what will happen that you can divide the denervation or the effects of denervation into acute, subacute, and chronic stages. The definition of acute is less than 1 month. Subacute is 12 months to 20, up to should I say less than 12 to 20 months. And this chronic is more than 20 months. In chronic, what will happen that there will be fatty atrophy, and which will be high signal on T1. There will be no enhancement on or no edema. But in acute, what will happen that there will be, acute enhancement, acute edema. Subacute will be somewhere in between. So our case is somewhere in between. If you look carefully, there is high signal on this T1, means fatty infiltration. And then on stir, there is a bit of edema and maybe a bit of enhancement. So it was subacute. On the other hand, look here, these are two different cases. This is a CT scan, and even on CT scan, you can see atrophy. And this one is from a stir sequence, you can see a lot of edema. This is another case which presented with, the clinical, when they saw the tongue, this was their clinical. They said that meningioma of the tongue ? And what we found is that there was high signal on T1 weighted sequence. This is stir, just a faint edema, just a bit of enhancement. So this was subacute. In this particular case, there was nothing no lesion was identified. So this can be a potential exam scenario. The examiner can show you this kind of case, and you will ask for rest of the imaging. You will go through it, and you might find a tumor or a lesion to explain the findings. But if you do not find a lesion, then you call it idiopathic hypoglossal palsy. Remember this concept. This is another patient. This is not this patient, but just to make a point, this is what happens. Okay, candidate 4, over to you.
So we've got a 42-year-old male with a history. We've got a 42-year-old male with a history of 6 cranial nerve palsy. So I'm just going to take a moment to interrogate the selective axial and coronal images on CT. So there is an area of low density within the left petrous apex, and when you compare it to the right side, it does look quite asymmetrical. And with that history makes me think about petrous apicitis and cranial nerve 6 sort of.
Can I ask you if your observations are absolutely correct, but there is one finding. If you see here, this is the petrous apex on the normal side, this is the abnormal side. And the abnormal side is what is happening to the bone.
Oh yes, so it's osteolysis and erosion of the bone.
Before that, because please
and
remember,
expansion.
Expansion. That's the key word, isn't it?
Yeah.
So yeah, osteolysis or erosion can happen just like that. So this is totally, what comes to your mind then? This is expanded like anything.
So this would be in the region of where you'd have the ICA and the carotid canal. So it does
So
make me think.
let me, you see this thing?
Yeah.
This is the,
So either a lesion that's within the
okay.
carotid
Do
sheath,
you,
or
do you want me to show you something?
an MRI or an angiogram.
Okay, so I've given you an MR.
Okay, so we've got a right-sided T2 hyperintense lesion that's expansile, and on the axial sequences, we can see that it's disrupting the bony anatomy.
Okay, madam, let me give you a hint. The key sequence to make the diagnosis is this T1. What is the signal? That is the hint from me.
So it's the same signal as fat.
Yeah.
And so it's a fat containing lesion. And
so you see there is an expansile lesion, means it is long standing. It has got this high signal. We'll come back to this. Why is it high signal? And it doesn't look malignant or infiltrative. So this is an Aunt Minnie case. Hint.
so a fat containing lesion in that location, which is expansile.
Fat containing, you know, you
Oh,
can take it with a pinch of salt. The word, there
okay.
will be some fat, but
So I mean, in that location, or maybe, sorry, maybe it's just sort of blood.
blood, excellent.
So an aneurysm,
Okay, so let me take
thrombosed
over.
aneurysm.
Okay, let me take over. It's an Aunt Minnie case. So this is a cholesterol granuloma. What is a cholesterol granuloma? Basically, the pathology is, or the pathophysiology is, cholesterol granulomas can be in the middle ear cavity mastoid, or they can be in the petrous apex when it is, aerated, etc. Basic concept is that, you know, uh, there is a vacuum phenomena, there is inadequate aeration, and gradually what happens, there is a chronic inflammation. Just remember that. It's a unique type of inflammation. This inflammation causes new blood vessels, etc. Very chronic, and I read a study in literature way back where they had documented a cholesterol granuloma developing in 22 years. 22 years, so because they had serial imaging. Now, what happens is that it keeps bleeding within the lesion, and so part of the high signal is hemorrhage. Part of it is cholesterol crystals. That is the concept, and it will cause expansion. So it's a unique type of inflammation, chronic inflammation. The radiology is Aunt Minnie radiology, and it will cause expansion. Now, what will happen that on a T1 weighted sequence, it will show you high signal, partly because of methemoglobin and maybe because of cholesterol. Mostly it is because of methemoglobin. Now, when you give contrast, you cannot see any enhancement. But having said that, on a T2 weighted sequence, at times you might see a hemosiderin rim, which is chronic hemorrhage. On a post contrast, sometimes you might see a subtle granulation tissue, which is enhancing. Key point is, it's an Aunt Minnie, and there is nothing else which can cause this. Please remember that aneurysms, there is no concept of aneurysm of the carotid canal like this, because an aneurysm cannot expand the carotid canal. It's a very tough bone. So this is a cholesterol granuloma, and this is from your book, books, well-defined expense style. So this is an exam case, by the way. This is another cholesterol granuloma. But the key thing, this is not very expensive, as expensive as the one which I showed you from StatDX. But the key finding is look at this T1. And if you look carefully on this T2 weighted sequence, you can argue that rim is showing hemosiderin. Another example from, I think, American College of Radiology. So it is causing this huge expansile lesion, and this is expansion, and you can see that there is a bit of a hemosiderin rim, cholesterol granule. So this is the last case of the day now. Candidate 4, are you with us?
Yes.
So this is the last case of the day, and maybe you already know the diagnosis, but the thing is that because we are doing petrous apex, I am showing you a scan which was this male patient presented with purulent porphyria with fever. So we can see that there is a lot of inflammation, opacification of the mastoidal cells of the middle ear cavity, etc. And this is the petrous apex. You don't see much there on this CT scan. And you can see a bit of aeration is there, but these are also opacified. This patient presented 5 months later with diminished, so he was clinically, he was dealt with antibiotics, got better. After 5 months, presented with symptoms of left eye with 6 nerve palsy. What comes to your mind with this clinical before I show you the scans?
So I'd think about petrous apicitis with Grada-Nigra syndrome, where you get a 6th cranial nerve, abducens nerve palsy.
Excellent, well done. What are your comments on this flare sequence?
So I know that the abducens nerve supplies the lateral rectus muscle. So if we did
can you describe
yes.
your findings? Can you describe it on the flare?
So on the flare images on the left side, we've got a high signal lesion within the region of the left temporal bone. And I'm just looking for, so there's also some increased signal within the anterior portions of the temporal bone on the top left image.
Yeah. So which portion is this?
Yeah, so it would be the petrous portion.
Yeah, and this is the clivus, and so this is unusual because we had done a brain type of protocol, so there was a flare. But the point I'm making is that even on a flare, because it is fat saturated flare, you can see something happening there. Unusual to see that. You can compare it from here. Now this is post contrast. What's happening?
So in the left side, we've got high T2 signal high T1 post-contrast signal and enhancement at the left side where we saw the lesion within the left cranial, anterior cranial fossa, anterior middle cranial fossa.
Inacme, madam, where are we? What is this? What is this? What is this?
So we're looking at the left region of the left cavernous sinus with the ICA.
Excellent. Excellent. So if you go back to this T2, even here, though it's not completely, but there was a slightly different signal here, right?
Yes, so I would
please.
think about cavernous sinus thrombosis and pus or thrombus within as a complication within the cavernous sinus, as a complication of the inflammation within the petrous apex.
Excellent. So if you see here, then we can see on this, cavernous sinus thrombosis here, and I will show you cases. I think maybe next session, where please remember that there can be secondary thrombosis of the ICA, and that is known to happen, and that can occur. What happens is that when there is cavernous sinus thrombosis, it's common sense because there is infection there, that infection will penetrate the wall of the carotid artery, and then the patient will present with stroke, complete occlusion of the carotid. So look for that also. So that should be your pertinent negative, that I can see the normal signal void of the internal carotid, but I can see this enhancement. There is cavernous sinus thrombosis. Now, some of the other that was done, and I believe there was some doubts on the, and just to make a point, nobody is going to show you a PET for this, but it was showing, this thing was on fire on the PET scan. So you dealt with very well, where this is the anatomy, and where you can see this is the canal, Dorillo's canal, 6th nerve. So 6th nerve can be involved. 7th nerve, and you remember the anatomy, because not 7th nerve, 6th nerve, and the other nerves which go into the cavernous sinus, they can be involved. So the definitions can be variable. If you see here from your book, uterus appendicitis, and this is the syndrome, retroorbital pain, lateral rectal palsy, plus otitis media, plus minus cranial neuropathy, which now 5 to 8 can be involved, because the infection, as this is the IAM, this is not far away, so this can also be involved. So this was uterus. Okay, thank you very much.